Prevention is so important, and it's definitely important for women, but it is, there's some differences about women. So we have our traditional way of assessing risk and saying somebody is at risk. First of all, we need to use that in women, just like we do in men. But we also need to be aware of risk enhancers that are unique to women and don't exist in men. Some things related to pregnancy, for example, if a woman experiences gestational diabetes or gestational hypertension or preeclampsia, or even has a preterm birth or has a small for gestational age baby, those are things that we should be asking when we're doing risk assessment and trying to do preventative therapies up front. There's other things that happen more frequently in women or only in women. For example, breast cancer and the therapies that you get for breast cancer are unique, obviously, to women. Additionally, rheumatoid arthritis and lupus, they're not unique to women, but they occur much more frequently in women. And we should be asking about those risk enhancers when we are assessing risk in women. There's other things related to polycystic ovarian syndrome or use of hormone replacement therapy, going through menopause, again, very sex specific. So knowing biological differences and understanding that there's differences in women compared with men is the key to risk assessment. It's a great challenge for us when trials are done and don't include women. We can extrapolate from those studies literally nothing. Although, you will hear investigators saying, well, the results should apply to women. That's not evidence, and we really need evidence. We need to include women in trials. And even here at the European Society of Cardiology Congress, we have seen a trial that completely excluded women. And as I put out on Twitter, unless it's a study about prostates, we should be including women. That makes it very hard when trial data come out. We don't know if it's the same, and we've been fooled in many ways in the past. We need, as a community, as a cardiology community, to really insist that women are included. Women are 52% of the global population, and we shouldn't make assumptions. As we've always said, women are not small men, and there is biological differences. I always say that, with women, and with men, you're biologically, every cell has a sex. So how we interact with medications or risk factors or how we respond to therapies is going to be different. And if it isn't different, it still needs to be studied so that we know if there is any difference. But excluding women from trials is certainly not the answer. Empowering women is so important. I think we've seen within the medical community that we undertreat women. For example, after a myocardial infarction, women are undertreated with guideline-directed medical therapies. They're less likely to undergo invasive procedures, and they're more likely to die when we compare them to men. And some of the solutions, of course, is to our medical community to help them change how they treat women. But I also believe that there is a role for us to empower our patients so that they can ask the right questions. First, they need to be empowered to work with their physicians about prevention, but that does require, a public health campaign at some level so that women can be educated about their risk and then know what questions to ask their physicians. When women go to the doctors, often what their preventative care is, I always say it's bikini care. Breasts, the reproductive system, and you ignore the rest of a woman's health. So if we can empower women to ask, what about my heart? Am I at risk? What do you know about my risk? That at least will start the conversation, because the heart is often ignored in women in a way that it isn't ignored in men. Women often don't know what their blood pressure is, they don't know what their cholesterol is, and they certainly don't know if they're at risk for heart disease. Whereas if a man goes in for screening, they usually come out with information related to their heart risk. I do believe that our campaign, we've been doing it in the United States for years, something called the Go Red campaign. I agree it's been effective, but I don't know if it's been fully effective. We know that about 50% of the population still does not recognize that heart disease is the #1 killer of women. So we still have a long ways to go, and I have proposed that maybe we need to revamp the Go Red campaign, and maybe we need this to be a global campaign as well. We know all over the world, all of us are struggling with these issues, and we know, if I'm talking to a cardiologist in Italy, they have the exact same complaints as I do. Again, why aren't women included in trials? Why aren't women getting the same medical therapy? Why are they having a higher mortality rate? And we need to partner with our patients so that we campaign, that we advocate for more funding for research in women, and that we solve some of the disparities in care that we have right now.